So thank you for joining our policy committee meeting. This meeting is being recorded. The documents which will be discussed here today are available on the event calendar on our website, which is wnc.wa.gov. I'm Amelia Boyd, and I am the program manager for the Medical Commission. I, along with Kayla Bryson, are the organizers for this meeting. Please make sure your line is muted if you are not speaking. Dr. Karen Domino is the chair for the policy committee meeting. Once the presentation is completed, Dr. Domino will open the floor for committee and public discussion. For those of you joining us via the GoToWebinar platform, the chat and the question area are open for comments and questions. If you are joining us via the telephone, please speak up if you have any questions once Dr. Domino opens the floor for discussion. Please refrain from making inappropriate comments or you will be removed from the meeting. And with that, I will hand it over to Dr. Domino.
Okay, well, welcome everybody. I thought we'd first start with our materials related in the order that I saw in the packet that we had. And there are three documents that Mike had included that involved communicating diagnostic test results to patients, transmission of time-critical information or passing the baton, and then a document which attempts to include both of those items in one single document, since if you recall the last meeting we had, our committee had approved the communicating of the diagnostic test results to patients, but it was brought up that it was very similar to this other document. Mike, can you fill us in a little bit about what you did here and sort of what you think about this, and then we can open up for discussion.
Yes, happy to. A few meetings ago, I brought forward the first document, which is an existing guideline for the commission, just for its 4-year review. There was nothing pressing about changing anything. And the commission suggested a number of changes, a few changes, and those are the changes that are marked there. Most significantly, specifying that this applies to diagnostic test results. But this is a fairly straightforward document telling practitioners that they really ought to tell their patients. I know that's obvious, but we have this document because we see cases in which they don't. At that time, I said I would bring it back in August for you to review the changes. And so I did. I brought it back at the August meeting with these changes that are there. Nothing's changed since then. And we started a discussion about how this differed from the TCMI policy, which was not up for discussion, which is not in front of you. There's a link to it, a hyperlink in the first document. So the second document is there. It's transmission of time-critical medical information. It's been, I think, reviewed twice. It's not a new document. And somebody said, can these two documents be combined into one? And that intrigued me, and I said I'd give it a shot. So the first document is about communicating doctor to patient, telling a patient about test results. The second document is doctor to doctor. So there's a clear distinction between the two documents. When I drafted the third document, I thought it looked pretty good, and then I started to have second thoughts. So the third document is merely a combination of the first two documents. So you can see from the title, it's both about time-critical medical information, sharing information between practitioners, and communicating test results to patients. And looking this over, the issue for me is this clear? Does it make it clear? Is there benefit to practitioners from having one document dealing with these two issues? And I tend to lean towards saying no. I prefer having separate documents. I think two documents, each dealing with a separate issue, is a little bit more clear, but of course I defer to you.
Well, I actually agree with you as well, Mike. One thing is passing the baton isn't necessarily clear to everybody what that means. I think you should, in the title, specify between medical providers or something like that. but I'd like to hear from other folks about what you think about it, because I think they are separate, and by changing the title slightly, people can understand that.
Dr. Domino, that was exactly my thought too, is that when we were looking at the text earlier, I don't think it was clear even to all of us on the committee that the demarcation, one is discussing provider to provider, the other is provider to patient, and certainly with the special duties of those two completely different types of relationships, I think maybe a title change. And Mr. Farrell, you've done a remarkable job on all of them, and I can't imagine how much work it was to try to put those two things together. And it's a great job.
Any other comments or thoughts about it?
Yeah, I agree. I think it ought to be 2 documents. But there's a couple of sentences in, I think, communicating to the patient document, which isn't up right now, that didn't seem to fit very well in the title.
Which one was that, Mr. Moore?
So
I
in
think
the
it's this one.
introduction, yeah, in the introduction, it talks about why you should do this. And then it said, second to last sentence says, it can also lead to a complaint to the commission. That doesn't seem to fit in this very well. Then unfortunately, studies confirm the commission's experience that many practices do not have good systems in place. Those are just negative comments that just don't seem to flow well when you're just trying to talk about what you should be doing for patients. It just, it could be just me. Those 2 sentences
Can you
just
point out where those are?
They are in the very first paragraph introduction, second to the
Oh,
last
gotcha.
statement, and the
Yeah.
last statement.
This is Chris Blake, and I agree with that, John. I don't think they really lend anything to the policy itself. And I also do agree that they should be separate policies.
Yeah, and I agree with getting rid of those things you mentioned, John. I agree, it's not shouldn't be in there.
Do we need
Any
a motion
other?
to strike those sentences, or just agree to do it? Or
Do we have Alden's on now? We have some discussion of this. Alden, did you hear what John recommended? I think Alden's getting in the system, perhaps. Yeah. Anyone else have any comments about it? It looks like Alden's trying to get in the system and get sound, and he looks like he's intent on his computer. Yes, Mika.
So I'll just go ahead and say that I know I sound like a broken record, but I think it's, from a customer service standpoint, it's beneficial when all of our policies are as consolidated as possible, especially when this one we are talking about test results communication. So I mean, whether it's to a patient or another practitioner, I think that it's likely that these could exist and be easier to digest by the average person who's looking for something like this, if they know they can get it all in one shot. Similar argument to rules, to having everything with respect to medical practice from the medical commission that you need to know about in the same set of rules. So I'm always going to just voice that and advocate for that kind of a approach, but I also respect the decision of the committee to keep them separate if they think that's the best.
Anyone have a comment about that? I mean, to me, they're a little different. Test results, I mean, you know, there are often issues with communication of that. That to me highlights the importance of that. The other one, time critical medical information, is a lot more than test results. And I don't mind that it's separate myself. Where one chooses to put it, I mean, if you organize a website as an example, they go under communication, right? I mean, it could still be in the same location, if not in the same document. But I'd be pleased other folks chat about it. Mike, John, Alden, are you there? I don't see Alden anymore.
Well, I'm still in favor of two different documents. You have two different audiences, same topic, I agree, but I don't know. This is just, they just seem distinctly different to me. Communicating about a patient and communicating to the handoff doc are two different things.
Yeah, I agree, John.
Two
Okay.
different duties, really.
Yeah, I think they're very different, and one's
Right.
broader than the other to me. And it also highlights the issue of the patient and communicating with them, which I think needs to be highlighted. Alden, are you on or are you off?
Can you hear me?
I can hear you, yeah. Can't see
I am
you now.
on, but I can't, yeah, no, I can't get the camera to work, and I can't on one. Having trouble getting it to work. In any event, I am on. I have missed much of this because I've been trying to figure out how to get this to work. So sorry. I did not have a lot of comments about this when I went through it.
We were talking about one versus two documents and some changes in the one of communicating diagnostic test results. Most of us thought that two documents worked better than one. Mike worked really hard on trying to combine them because one is provider to provider and one is the provider to the patient, and they are different. The couple of comments about it, one was that passing the baton isn't obvious to people. It's sort of a fun little sentence for their phrase, but I think it needs to be explicitly pointed out from healthcare provider to healthcare provider. You know, that's because I don't know what passing the baton means, and I think a lot of folks don't. And then the one for the patients, there were changes in there, and John had recommended deleting some of the sentences in the first paragraph of this thing shown up there, which include it can lead to a complaint to the medical commission. And unfortunately, studies confirm the commission's experiences that many practices do not have good systems in place, along with that reference that's cited. And so that's up for discussion. I thought it was a good idea, and I wonder if anyone has any other thoughts about it.
And John had a problem with it. I mean, the statement's true. The question is it helpful?
This is Chris, and Blake, and that was my, that's what I was wondering too. Does it really lend anything to the policy? And it does have sort of a negative connotation, yeah, to the commission. So I thought that it wouldn't hurt to delete those two sentences as well.
Yeah, when I read it, it didn't seem to fit. It's not they aren't positive statements or negative oriented, slap your hand type of statements. And we're trying to have a nice statement dealing with patients. So didn't seem to fit to me.
Any other thoughts or conversations about that? Does anyone want to? What do you guys think in terms of recommending approval? I think we'll do one in terms of the two documents versus one. You want to do that as first?
Do we have good language on the second document rather than passing the baton.
Well, we have to do with that too. I just want to move it, see if we all agree that we don't want two documents. We want two, excuse me, we want two documents and not the one.
Yeah, I'm in favor. Well, I'm in favor of two, but that's.
I am too. I think it's a matter of title. It seems like just a change of title would really clarify things, that we're speaking provider to provider communications versus provider to patient communications, where yeah, there's a lot of overlap, but the duties are completely different.
So would you suggest getting rid of passing the baton and put provider to provider or healthcare provider to healthcare provider? Or what language would you recommend?
Either from one healthcare provider to another healthcare provider, or between healthcare providers, among healthcare providers. Presumably, it's still patient information. So it's all geared toward making sure that the patient gets the information or the patient's other providers get information so that they get appropriate care in one case, and then informed consent in the other, and possibly if they're kind of, yeah. What do you think? Between providers, among providers?
Aren't we trying to say direct communication between providers? Isn't that what we're actually trying to say?
Yes.
Yeah. Yeah.
About
So
patient
this
medical
happens to be
information.
one off, right? Mm-hmm.
Yeah, and Mr. Molden, I think you had a good point. Direct provider communication about patient, or however we call it.
So instead of passing the baton in this, we'd put direct communication between healthcare providers or between providers? What would you guys like?
Between providers of time critical patient medical information.
Yeah.
Sorry, can you say that again so Mike gets that?
Direct communication between health providers for time critical information.
Right. Time critical patient medical information.
Mike, do you have that?
Yeah, I think so. Direct
You wanna read it?
communication.
Yeah.
Yeah, direct communication between healthcare providers of time critical patient medical information.
Good.
Good.
You want to say patient and medical?
I think so. Just me.
I think that's more than necessary. And if Warren were here, he would say more words is bad.
Yeah. And I
He's
think
not
the
here.
of patient information should go ahead of two healthcare providers. Just saying, it's Chris.
Mike, did you want to read it to us again, what our current thing is? It's hard to follow.
Yeah, did Chris, you make a suggestion?
I did.
And
The phrase with the starting with of critical information should come before two, and it should be between healthcare providers. If you read it again, I wordsmith this stuff all the time at the hospital, so I just, yeah.
Yeah, I think I know what you want.
Yeah.
The way it says, the way it reads now, direct communication between healthcare providers of time critical patient medical information.
Right, and put the direct communication of time critical health information between healthcare providers.
yeah, that sounds better.
Yeah, agreed.
Yep, okay.
I agree.
Okay, so we have that change in this document of the title. Anything else in that document? This one was approved in what, did I see 2018? Yeah.
So just a point of clarification. This document was not on the agenda. It's the first document that was on the agenda. So for the agenda tomorrow, we'll have to modify it slightly, I think.
It was included in the packet though.
Yep.
So, I mean, that's where I have my copies from, the packet.
So Amelia,
So yes, it was provided because it's being referenced in the third document, the combined document. So if we do make changes to the TCMI document, we'll just have to amend the agenda for tomorrow. It's not a big deal.
So can I make a quick trip back up to the second paragraph that starts in 2011? There's a sentence in that second paragraph that reads, "The commission issues these guidelines to assist practitioners to communicate." It would read better if you said to assist practitioners in communicating test results.
We're back on the diagnostic test results. Okay.
Yeah, and I'm sorry because I couldn't get on when I wanted to, but that would be my only other thing. It just would read better, and it's not essential.
Say it again, Alden.
I would, whoops, hang on. I would just say it starts, the commission issues these guidelines to assist practitioners to communicate. There's one too many twos in there. And I think it would read better if you said the commission issues these guidelines to assist practitioners in communicating test results directly to patients.
Yes.
Yes, good.
So would we strike out the transmission of critical medical information to providers, practitioners?
In that line I just read?
Yes.
No, the only thing you do is change to in, and then change communicate to communicating.
Okay. Great. And we should have terminology like practitioner versus provider be the same, and the title reference, the title or whatever. I mean, I think we use the word practitioner versus provider, and we should just use the same word in all the documents relating to healthcare providers.
Yeah.
Great.
Okay. Any other discussion of this?
tiny little matter. When you took out the two sentences at the end of the first paragraph, that deletes a really nice footnote. So can I take that reference in the footnote and just stick it on to the resources at the end?
Sure.
Okay.
Yeah, I think so.
Less is more. Do we need the word diagnostic in the title?
I think it got added because we wanted to emphasize that. It makes people, I mean, just thinking of missing a lung lesion on a chest x-ray, it's an incidental finding, it's a diagnostic thing. I mean, I don't know, it's true tests are diagnostic, but I don't know. I didn't mind it. Anyone else?
I actually agree with
it.
you. I actually agree with you, and part of the reason is because I wouldn't. There's a lot of stuff I wouldn't include with test results. I would just think about that as being laboratory tests. I wouldn't consider, and that may just be me.
No, I agree with, from a facility standpoint, I agree with that the diagnostic test results to patients is good to have in there.
Any other discussion? No. I'd like a motion, or can I make the motion? I always forget this parliamentary procedure thing. So for approving conditionally with these changes that we had made. Yeah. Anyone want? Mika, you want to mention something?
Amelia, it appears Jeb has a question.
Oh,
I'm
Jeb
working on that.
Okay.
Yeah, I'm responding to him in the chat box.
Okay, cool.
do we need to wait till we hear what the question is? No? Okay. Anyone?
I move to adopt the two documents as revised.
Second.
Okay, all in favor?
Aye.
Anyone against? Okay, we'll take that to the full group tomorrow. All right, we'll move on to our second item, which is clinical experience limited license. Mike, do you want to talk about this?
Yeah, so this is from Senate Bill 6551. We are required to make rules to create a license for limited clinical experience for international medical graduates. So the model that we're talking about is under 18.71.095, which basically requires a agency head or someone in leadership to sponsor or vouch for someone before they'll get a license. So if you're familiar with residency process, residency directors issue those letters to us all the time. So it's the same model. They would, except this would be open to open the IMGs to be able to do a couple of things. One, they could attend tuition-based clinical experiences. It would also allow them to have a clinical assessment conducted on them, and the IMG work group right now is actually debating what model to use and apply for that. That also will be coming to you for rulemaking once they decide on their recommendation, and so we would need to adopt that as well. So that's a future thing, probably more around the April-May timeframe before you'll see that. That being said, this is the language that the IMG work group worked on with staff, and this is what they submitted as their recommended language. So at this point, it's up for your consideration to comment on, ask questions on, and then the next step would be to send it forward to rulemaking. If I'm correct in my memory, you have already, as a commission, approved rulemaking as a 101 for Senate Bill 6551. So you wouldn't have to open a 101 or anything. This would simply be choosing to move this language forward and start that rulemaking process.
So, because since I'm new to this process, I wanted to know, does the rulemaking expand what is listed in here, or does the rulemaking pretty much just leave it as is?
There's a part of this that I'm going to defer to Amelia on because she is our resident expert, but as far as expanding the scope, no, it wouldn't. It would be able to expand the scope if the language changed. But again, we were on workshops as part of the CR 102 process, I believe, and during those workshops, 101, and as part of those workshops, we take comments, and the panel can choose to alter the language as they believe should be fit. And so in that sense, it could expand it. The fact that this is rooted in 1871's concept is going to limit the license on its own, just simply because it's never going to be a full license. It is always going to be in that limited category.
Well, its function is to function in the limited category, though. It's to get people experience, just like the residency thing is. We don't want it to be a license. Once they get the experience, then they have the opportunity to apply for the license.
Mm-hmm. Well, this is actually preparation for them to go into a residency.
Right.
So one of the things when you evaluate residency candidates are things that are difficult to evaluate in a lot of the folks. And one, I had a couple just questions. So because I do know we do have international faculty, medical trained faculty and residents within our system, and they're excellent. But occasionally we do get ones often coming into, just from my department, fellowship programs with who look good but can't practice at a level that we expect them to. Their level is below the level of one of our interns, who is not even in, so they're fairly low level. And there are a couple issues that we see. One is, how do you evaluate this? And that's a challenge. And the other, and is there a lower bar for performance, other than because not all medical schools are the same in the world. And then the other big thing deals with lapse in clinical care. I mean, it's hard enough for experienced practitioners to take a number of years off from training, from practice, and that's hard enough. I mean, and if you know how to do what you're doing, it's not that difficult to get back in the swing of things. But for someone right out of school and training in their country, and suddenly now it's 5 years later and they're here, that's a big leap. And what sort of safeguards are? I mean, those folks and I'm supportive of this, because I know they can't even begin to apply to our training program because they don't have the experience. They don't have recommendations locally. They just can't get it. And but on the other hand, without the safeguards around this, I wonder how is this going to be decided? Is it just to be safe for the patients?
Sure. So I can't answer all of the questions because some of this is still being hashed out by the IMG work group. What I can give you is, in the words of my grandfather, a vague conceptual framework. And so basically, let's imagine you've got what is a common refrain about a IMG who was in their home country. They finished all of their training there, and maybe they practiced for 5 years, but they've been driving for Uber in Seattle for the last 7 because they can't get into a residency. They've attempted to match. They've completed ECFMG and all of the USMLE tests. And so what the apparent issue is the length of recent clinical experience, the length of time since they've had that. And rightly so, it's difficult to assess this. So the model that at our meeting on, I believe, Tuesday, at the IMG work group meeting that was discussed, utilizing this proposed license, is number one, you've got someone who is essentially vouching that this person will be supervised and seen over in either the tuition-based clinical training program or some kind of rotational assessment program. But either way, it's in an institution. It's not that they can go to a clinic or something and that's not licensed or anything like that. So there are safeguards in that regard. The other piece that I mentioned briefly is, I don't know if you're familiar with Dr. Judith Powell's at the Family Medicine Network, but she presented a clinical assessment tool that is likely going to be recommended by the IMG group and will come to you for consideration and adoption. I believe she said it was developed by the AAMC, and it has 5 different trust levels. And so while they're doing these clinical experiences, there's intended to be an evaluation of them, which will, one, set up the evaluation criteria so people will know on a trusted scale what we're talking about with the skills of this person. They will get the recent clinical experience, and it will also end in as you said, letters of recommendation from local people who've actually worked with them hands-on and know their skill levels over, and as they were describing, a minimum of a month's time of work. And so and depending on the specialty, there was discussion of it having to go longer to be more appropriate for the observations.
Yeah, a month isn't very much. I mean, and if you're looking at trainees, we're observing people 4 to 7 years a lot of times before they're out. And they still have a provisional license as opposed to getting a regular license. But do you know what
just to be clear,
areas will? What? I'm sorry.
Just to be clear, this is only the observational piece and the assessment piece to set them up to go to a residency. It isn't to set them up to get a full license.
Yeah. It'd still be hard for a lot of residencies for 1 month experience. We do see that in people, but it's still it depends on the quality of their experience.
Right.
Who is going to be providing these experiences? I mean, I know, like, being in a teaching institution, we're already full with our own trainees.
That's one of the questions that I can't answer yet. That's something that the IMG work group has to sort through. One, on a funding level, how do we? They've been given authorization to grant out funds, but they've not been given any appropriation yet or a dedicated fund. But the concept that this would just get taken on in existing resources has not been accepted at all. That's not going to happen. So everyone's pretty aware on that. And to be clear, the month that I was talking about is purely the assessment piece, not the clinical experience piece. So the clinical experience, according to this language, could go 1 year. The maximum it could go is 2. And during that time, 1 month, generally thought to be the end of whatever the time frame is, would be the assessment time frame.
Okay. So what are we supposed to do with this, Mika?
Well, this is presented to you for review and comment, and then I don't know if we've got enough people to send it to rules, or does it have to go
No.
to full commission tomorrow?
This is only for review and comment, because this particular language has not been workshopped. We do have a 101 in place, and it is on the screen. So that's the scope of the rulemaking we're doing, which is in that first paragraph. So we haven't workshopped any of this yet. So it's just for feedback from the committee. So there's no decisions that can be made on this today. And then Jeb Shepard with WISMA does have some comments.
Sure. So one question to you, Amelia: can they make the decision to send it forward to rulemaking?
No, there's already a 101 open.
Okay, right. But as far as just saying, okay, let's send it to a workshop.
Right. So they can provide feedback on this draft, and then we can incorporate that feedback and then have a workshop. So, but that's what they can do. They can provide feedback. Anyone can provide feedback, so not just the committee.
That's the ask, Dr. Domino.
Okay.
And then,
so,
okay, let me.
Amelia, do you want to let in hear from the WISMA?
I've unmuted him.
Yeah, hi, can you hear me?
Yep.
Yes.
Hey, good evening, everyone. This is Jeb Shepard from the Washington State Medical Association. Thanks for the opportunity to provide some comments on this. So the Medical Association supports the concept of finding a way for qualified IMGs to provide patient care here in Washington State. Have a key provision that we'd like to see retained, and then some questions and concerns. So I'll start with a provision that we're particularly pleased to see, and that's the requirement that the IMG demonstrate that they've been a resident of Washington for 2 years. I think the intent here is to find a pathway for IMGs that are residents of Washington, and we'd have concerns if our state sort of became a magnet where physicians, the current physicians here, including IMGs, would have to compete with folks from other states to get that clinical experience. So we'd like to see that stay. I just want to call out our support for that provision. Some areas of where we have questions and concerns, they're threefold. So one, the supervision requirement, as we read it, is problematic because it doesn't require, by our read again, a direct supervision. So ostensibly, you could have, you could read this to permit a physician that's off-site to supervise or someone doing it remotely. And by my understanding, I don't think we even allow current medical students to do that without very close supervision. So the way that I've contemplated this should be more closely aligned with like job shadowing to get that clinical experience instead of a supervision that doesn't state that it has to be direct. And sort of to that end, we'd like to see language that ensures IMGs are practicing in alignment with what they were trained to do and what they have experience with, so that we don't get someone who was trained in primary care coming over and doing spine surgery or something. So we think it could be improved there. And then finally, just a question, and you may not have the answer, but just something that we probably should be thinking about is what are the implications here for medical malpractice? So are these IMGs covered by the facility that they would be getting this clinical experience at, or would there be another pathway to get that med mal insurance? It's just something that we want to raise.
One would assume the program would cover it, but I agree, it should be specified. And the direct supervision, I mean, that's one of the things that we work with PAs too, and a lot of times you see that the supervision is extremely indirect. And for these folks, the direct, I think, is important. I agree with that. I don't know what other people think. So I thought those were quite good comments. Anyone else have comments about it? Alden?
Yeah, I was just curious, what's currently done with medical students? Because I think that's kind of what we're looking at this as, is we'd like it to be as close to what we do with medical students as we can.
Well, for us, they're unlicensed, so we don't have much of a say, and we don't have statutory language to draw on either.
Well, but yes, and these people are also unlicensed. And so the other part of this would be, what does malpractice do as it relates to medical students? My understanding is that it's on the instructor who is on the line.
Yeah, and I don't know in the university. I do know our residents are separate. Faculty and hospitals are, I mean, it's complicated. They'll allocate portions to individuals, but medical students are unlicensed, and they are always under direct supervision. They are never alone. It's very different from old days where there's more freedom for them.
I think there's a difference between.
They do a lot of the I mean, they do their own assessments, but none of those go in the chart anymore because of billing issues.
Residents are typically covered by the institution where they are working. I guess technically they're still students, but a real student, like a second-year student, not licensed. I don't think they're seeing patients, but they are learning, and they would not be covered by a professional liability program.
They'd be covered by their medical school, I assume, is where it would come from.
It depends on what. It depends on what they are. Depends on what they're doing, what they are authorized to do.
I think Jeb's comments are very, very germane, and we should consider how we can best work those in.
Yeah,
and
so
I'd be happy to follow up in writing with these.
Sure. So just a couple of comments. So the 2-year thing was actually the IMG work group is in agreement. They were pretty insistent that be there. As far as the supervision, you may recognize that we did lift straight from the statute on, I believe, PAs. but that was not a point which they felt amazingly strongly about. So I think that the alteration to more direct supervision is going to be fine.
Do we want to, how do you want to handle this? Because there are changes, I think, that should be made. Do you want to have us bring it back and delay things? Do you want to hear from other commissioners about their thoughts about it? Which would, what would the group like?
Well, part of rulemaking is coming up with the language, isn't it, Amelia?
Yes. So again, you're not going to make any decisions today. What you can do is you can provide the comments to me or to Micah directly. And
Probably should be Amelia.
Do what?
Probably should be Amelia.
Right. So we actually have a medical email, a rules email address. So I'm going to pop that up on the screen. So if you have any comments, you can send them to that email address and they can be sent on to the rules committee for this particular rulemaking when they actually do have a workshop sometime in the near future.
So for tomorrow then, would you like to just show this slide, do a little explanation of this and then show the slide and then have people do that to reduce the discussion?
Sure, we can do that. Probably ask Micah maybe to explain what he needs. And then if anybody has any questions at that point, they can ask him if they have questions similar to what we've done today. And then, yeah, we can provide the email address if anyone has any comments on the draft language.
Yeah, and that's because I was unclear because when I started off, there were all these things that seemed to not be in there, but basically the rules committee rulemaking will do that.
Correct. And then you'll see this again in the future because once they are done with the language, they will bring it back and request that we initiate the next step in the process, which is the 102.
Okay.
I like to make sure that the policy committee bookends things.
Right, right.
Yeah, okay. Good. Any other comments about this? No? Okay. Any other things that we should bring up today? Or can we all head home?
Melanie is proving that Squim actually has broadband internet.
Okay. Well, then if I don't hear anything else, we'll adjourn this meeting. Mike, will you please send out to the commissioners the changes in those documents that we did earlier before the meeting tomorrow? Great. Thanks so much. Bye, everyone. Have a good evening.
See you tomorrow.
See you tomorrow.
Bye.